Good morning. Welcome back here at the ESCMID Global TV studio, brought live to you from the ESCMID Global here in Vienna, Austria. My name is Judith Cohen, and I'm very happy to introduce to you my new guest, Professor Jay Fishman. Jay Fishman is a professor of medicine at Harvard Medical School. He's also the director of the transplantation infectious diseases program at the Massachusetts General Hospitals. And you were also the keynote speaker of the keynote with the title Infections After Solid Organ Transplantation Through the Looking Glass, Past, Present and Future. And that is the reason why we invited you here to come to our TV studio, so we can give our viewers a little teaser and show them why they should absolutely not miss out on your keynote lecture, which will be held tomorrow on Sunday, the 13th of April at 9:30 in the morning in Hall 1. A warm welcome to you, Professor Fishman. I'm very happy to have you here. Are you looking forward to giving your keynote lecture?
I am. It's an honor to be invited, and it's a great pleasure because this is an expert group, and I take care of a subset of patients who are particularly interesting to me. So it's fun to share that experience when you're at one end of your career as opposed to the other.
And you probably don't often meet that many experts in the exact same field.
So when I started in this field, there was nobody. Except my mentor, but we gradually built this into a community, which is an international community taking care of immunosuppressed, immunocompromised individuals around the world who have had stem cell transplants, who've had organ transplants, of other forms of immune suppression, and are highly susceptible to infectious disease. So this is really a sentinel group of individuals for this Congress, the topic of this Congress, which is infectious disease.
So you'll be looking into the past also. How have infections after solid organ transplantations evolved over the years?
Well, one of the biggest things, of course, is very often when I started, we didn't know what we were looking at. We didn't have diagnostic tools, and even if we had diagnostic tools, we didn't have therapies. So that this has evolved through a lot of work in microbiology and assay development. I'll talk about that a little bit, but I think that the biggest is suspicion in this group of individuals that infection may be going on. They are complicated patients. Yeah. They have graft rejection, they have infection, they have drug toxicity. And our job as infectious disease and microbiology specialists is to sort that out.
Yeah. So can you sketch a little bit more how that was when you first started out? Like probably the most transplantations were livers, or?
Most transplantations at that time were kidneys. And some hearts. Of course, we do hearts, lungs, kidney, pancreas now, bone marrow and stem cell. What we had to be at that time were expert bedside clinicians. Yeah. And my teachers would go in and look at the patient, examine the patient, and tell me what was wrong with them. And it was magical because we never knew how they got to that particular state. But for those of us who are in a more modern or transitional era, we started developing tests to figure out what the natural pattern of disease was in these individuals. And because we knew that, we could develop preventative strategies. We could develop vaccines and antibiotics that we'd give to people on an individual basis to prevent the common infections. That meant survival was going to be increased tremendously. Yeah. And so as the patients lived longer with their immune suppressions, they got new diseases. Yeah. And so we were making, if you will, business for ourselves because patients were doing better.
Smart business.
And then they change the immune suppression and we have to develop new strategies. So it was exciting all the way through, and still is very exciting because there are new chapters that we're entering right now.
Yeah, so I can imagine changes were emerging really fast, even just blink once and there's a new...
The drugs that we had to prevent graft rejection were fairly crude when we started. And what would happen is we develop a new drug and the pattern of disease would change. And so we had to learn to match our infectious disease expertise to the drugs we were using routinely. We also learned, and we started some new groups that would look at diseases that came from the organ donors. And that was new. We didn't even think about testing the organ donors when I started, and now it's, of course, routine worldwide.
It's unimaginable that was the case.
And when you look back at it, you say, how could we not have done that?
Yeah.
And so we've started various groups and interest groups and clinical research groups that have really rapidly advanced the field of infectious disease.
Yeah. So looking back at the past, probably you wouldn't say that organ transplantation was quite safe. Looking at the present, there are ways to make it more safe. Are there still unmet needs, and what are they? Can you touch on that?
Well, so the first successful kidney transplant between identical twins was in 1954. That's not that long ago. And right now, kidney transplantation is routine. And the immunosuppression for all of the organs and for stem cell transplants are fairly routine. There are variations, but it's fairly routine, and the monitoring that we do is fairly standard. They still get unusual and interesting infectious diseases, but it is a challenge to make these diagnoses still. What are the new frontiers? Well, part of it are the new drugs we're using. We have new immunosuppressive drugs that are going to cause new problems in infectious disease. I'd like to take you to the end of the story first, and then we can work our way backwards. So we've just completed a couple of pig-to-human kidney transplants at Massachusetts General Hospital, so xenotransplantation, which poses the entire question of what organisms could potentially be coming from pigs that could set up in humans and cause new diseases, and for which we'd need new therapies and new diagnostic tests. So
you still call that zoonotic
we call it zoonotic infections.
Because you're actually putting the animal in the human.
We call it xenozoonotic just to make it sexier.
Yeah.
But you know, one does what one can. But the idea now that you can develop donor pigs in isolation that are tested for hundreds of organisms suggests that on a microbiologic basis, this might be safer than using human donors. The key here is we're short of organ donors. And so that if we could address the shortage of organ donors using pig organs, that would change the complexion of transplantation. We could take one off the shelf and give you an organ when you needed it. That would be pretty exciting.
Yeah. Yeah, it would. Yeah. Is it possible, you think?
Well, so...
Which hurdles are there still?
The organs are not completely compatible metabolically, so there's some things to learn about pig organs in people. But what we've learned is with new genetic techniques, we can modify the pigs such that the immunologic rejection is reduced, that blood doesn't clot in these new organs, and we can exclude an organism that I worked on for years, this porcine endogenous retrovirus. We can knock it out genetically so the pigs don't even have it. So that it means that we can modify these pig donors in a way that makes them safer and more acceptable and work better in this new environment. But we still don't know how well these complicated organs will work in their human recipients.
So at this time, at the present time, you'd still rather do a human-to-human transplantation?
At this time, I'd like to do both. We certainly need to do human-to-human transplantation, and that's not so simple either. But if we can figure out the hurdles in pig-to-human transplantation, we can address inequities in organ availability, we can ship organs around the world, we could potentially freeze them, we can test them microbiologically, so it's a very exciting time from that perspective.
And what is necessary to progress to that point? Is it better testing, molecular testing, immunological testing? Is it better drugs, immunosuppressants? Is it?
It's a little bit of all of the above. I think first it's some agreement on what it is we should be testing for. We have to develop standardized assays that are used across the entire field, and a lot of those are molecular tests, nucleic acid tests. We have to know what those diseases might look like in humans if they do occur. But in general, if we screen out these infections before the organ ever gets to the human, it should be quite safe from a microbiologic perspective. Yeah. If the organs do what they're supposed to in the humans, then we've got a very big opportunity to reduce the organ shortage.
Yeah. So for who is your talk, your lecture interesting? Is it for infectious disease doctors who work with solid organ transplantations only? Or would you say, well, people interested in zoonotic infections or One Health, they absolutely have some interest being addressed there?
I don't think it's just ego to say it should be interesting for everybody. It's partially that, I'm sure, but the reality is we're developing new diagnostic tests, we have new frontiers, but the immunocompromised patient is a sentinel for all kinds of infections, and most infectious disease people are now seeing more immunocompromised hosts in their practices, regardless of where they are. One common extreme of this, of course, is diabetes. Yep. So we see people with variability in their ability to fight infections every day, and then there's the heavily immunosuppressed individuals that we see less often. So I think it's an exciting area to look at new diagnostic tools, and then certainly at zoonotic infections, and how much can we learn about making rapid diagnoses and developing new therapies for these new diseases.
Yeah, there's still so many lessons to be learned, not just in 1954, but yeah.
So it's an exciting
time. Even though there's more known.
Yeah. No, it's fun still.
Great. And you'll also be hosting a fireplace session, I believe, after.
Yes, a fireside chat after my talk where I get to be asked the questions that I didn't answer during my session. So.
Yeah, or questions that people were afraid to ask in the large plenary session. You never know. Well, this is absolutely wonderful. Thank you so much, Professor Fishman, for coming here at ESCMID Global TV and sharing with our viewers a little bit of what you're going to be talking about on Sunday, April 13th at 9:30 in Hall 1. Please don't miss out on this. This is going to be interesting, for I think, for a large group of participants here at ESCMID Global. So make sure to not miss out on that, and we hope to see you back here at ESCMID Global TV for more interviews with other lecturers. See you then.